to save somebody. So at the point that we do intervention, there's always we do the risk analysis. If the benefit is more than the risk, we do anything. So that is the reason.
Okay, thank you, Manish and Tusira. And this question is for you, Manish, regarding to your lecture. In the ICU, when we decide to intubate a patient who might be having a serious respiratory problem, is it better to perform early bronchoscopy rather than late bronchoscopy while waiting for the response to mechanical ventilation and other possible treatments?
So Ruth, this is an important question. Whenever you are seeing a patient who is fighting to take a breath, the idea is to stabilize the airway breathing and circulation as early as possible. I don't think the question should be asked that whether I should do early versus late. It should be done when the window is optimal, right? And majority of the time, this window is early in the clinical presentation. First of all, you must ask this question, the patient who needs an intubation. Let's say the patient is coming as a respiratory distress. Are you going to tube this patient because of the mucus plug? And in case if you're going to tube this patient for the mucus plugs, because conventionally we have been trained to tube the patients who have been having an hypoxemia, right? Now in that situation, is it going to help you in averting the situation? Is it going to help you in retrieving the mucus plug? In case if it is not, it's time for us to understand and upgrade our skills that you can actually manage them when they are on non-invasive ventilation or HFNC, so that you can provide the macropatency of the airway and you can refrain from putting them on mechanical ventilation. So maybe, Ruth, I may be biased for it, but my idea is very simple. Unless and until you treat the reason for which the patient is there with you, you're only going to make the mess of the situation. So you have to identify which one is the trigger for your patient to be in ICU and settle that trigger as early as possible during the clinical course of the patient. What is your take, Tushira?
Absolutely right, because I will take you back to, I practiced the last 27 years. In the last 35 years, the 27 years of I practiced as a doctor. About 27 years back, every patient who came to the ICU, they were tubed. There were no NIVs, HFNC, these techniques were not given there. So every patient was used to tube. Now we have people who are on NIV. That means we want to prevent the mechanical